Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Hepatitis C and Substance Use, Addressing Screening, Linkage to Care, Treatment, and Stigma. And our presenter is Dr. Kelly Ramsey, Associate Chief of Addiction Medicine for New York State OASAS. She will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. The goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Okay. Thanks everyone for tuning in. So first, let me go over the learning objectives for our talk today. Review the epidemiology of hepatitis C among people who use drugs, describe hepatitis C transmission among people who use drugs and the role of substance use in hepatitis C transmission, discuss the importance of screening, linkage to care, and treatment of people who use drugs and available treatment regimens. First, we'll discuss the epidemiology of hepatitis C among people who use drugs. So clearly, there's a high global prevalence of hepatitis C. You can see that the highest regions here with a prevalence rate of greater than or equal to 5% are primarily in Africa. The United States has a lower overall prevalence. However, it's particularly high in the community of people who use drugs. If we look now at the United States, the highest prevalence of hepatitis C is actually in 9 specific states, one of which is New York. So more than half, or 52% of all people living with hepatitis C nationwide are found in only 9 states, and those are shown here on the graph. So what are the actual recommendations for hepatitis C testing as per the CDC? These were just updated in 2020. So the CDC now recommends one-time hepatitis C testing of all adults 18 years and older and all pregnant women during every pregnancy. The CDC continues to recommend people with risk factors, including people who inject drugs, be tested regularly. Hepatitis C is both under-recognized and underdiagnosed and rising in incidence in the United States. So actually, 3 out of 4 people living with hepatitis C do not know that they're infected. And from 2010 to 2014, new hepatitis C cases in the US increased by about 250%. Let's look at the incidence and estimated incidence of acute hepatitis C in the United States. On the left-hand side is a map that's showing acute hepatitis C incidence by state in the United States, and this is from 2016. So the states that are in dark blue are at more than twice the national goal for incidence of hepatitis C. And on the right-hand side, we have estimated number of acute hepatitis C cases. So unfortunately, acute cases are highly underreported in the United States. So the actual number of acute hepatitis C cases versus the estimated number of acute hepatitis C cases is quite different. So you can see here in this graph, which looks at data from 2013 to 2017, that the vast majority of acute hepatitis C cases are not reported. They're estimated and not reported. If we look at the incidence of acute hepatitis C by age in the United States, you can see that the group with the highest incidence are 20 to 29-year-olds. If we look at risk behaviors and exposures with reported cases of acute hepatitis C, you can see that for the majority of cases, the risk data is missing. For 13.8% of the cases, no risk is identified, and only for 38% of the cases is the actual risk identified. For reported cases of acute hepatitis C by risk, exposure, and behavior, you can see that injection drug use is the #1 reported risk, exposure, or behavior. For reported cases of hepatitis A by risk, exposure, and behavior, you can see that injection drug use is the second most common reported risk, exposure, or behavior. If we look at co-infection statistics in the United States, about 21% of people with HIV also have hepatitis C. Between 62 to 80% of people who inject drugs with HIV also have hepatitis C. Having both HIV and hepatitis C more than triples the odds for liver disease, liver failure, and liver-related death. About 11% of all new hepatitis B infections and 21% of all new hepatitis A infections were among men who have sex with men in 2017. And the number of acute hepatitis C cases more than tripled from 2010 to 2017. If we look at locations in the United States at risk for a hepatitis C and HIV dual outbreak among people who inject drugs, you can see that there are a lot of hotspots around the United States. So the pink hotspots are the top 220 vulnerable counties in 26 states. And the green on the map indicates jurisdictions determined to be experiencing or at risk for dual HIV and hepatitis C outbreaks. And again, this reminds us of what happened in Scott County, Indiana, at the end of 2015, early 2016, when you had a dual hepatitis C HIV outbreak in a small rural community. If we look at the data of hepatitis C and injection drug use in New York State, you can see again that there's a large bump in the incidence of acute hepatitis C, but also of chronic hepatitis C among young persons. And you can see on the right-hand side of the graph that at the baby boomer age group, it actually has far lower incidence than the younger age group. So let's look at hepatitis C incidence and prevalence that is attributable to injection drug use. So when we look first at the United States as a whole and look at incidence, in 2017, there were an estimated 44,700 new cases of acute hepatitis C. Among case reports that contain information about injection drug use, 86.6% indicated injection drug use prior to onset of acute symptomatic hepatitis C. If we look at the United States prevalence, an estimated 2.4 million Americans are living with hepatitis C. Again, and remember that about 75% of those individuals are not aware that they have hepatitis C. If we look at state incidence in New York State, there were approximately 188 new cases of acute hepatitis C reported in New York in 2017. And if we look at state prevalence, in New York, there were an estimated 116,000 persons living with HIV in New York in between the range of time of 2013 to 2016. So let's look at hepatitis C transmission among people who use drugs and the role of substance use. So transmission of hepatitis C is done most efficaciously by parenteral or injection drug use. That is the most efficient way to get hepatitis C. However, it can also be transmitted via sniffing drugs, skin popping, and smoking. It can also be passed perinatally from a pregnant person to the fetus, and it can also occur during sex, particularly rough sex that has been most associated with anal sexual intercourse among men who have sex with men. It is not considered to be transmitted sexually via vaginal sex. If we look at defining populations of people who inject drugs, you can see that there are lifetime people who inject drugs, current people who inject drugs, and then there's an intersection between people who inject drugs who are on treatment with medications for opioid use disorder. All persons in these categories are at risk for hepatitis C and should be screened for hepatitis C. So as I mentioned, injection drug use is the most significant risk factor for hepatitis C, and that's on a global basis. And this is for several reasons. Hepatitis C can survive on what we call works to prepare drugs for injection drug use. So that includes cookers, cotton filters for days and longer in the needle barrel. And we'll go over that information in a few moments. Hepatitis C is transmitted at a 10-fold rate relative to HIV. In other words, it's far more infectious than HIV. 80% of new infections are related to injection drug use. Young people who inject drugs have a propensity to share needles and works, and hepatitis C is often acquired shortly after individuals begin injecting. And it's estimated approximately 64% of people who inject drugs in the US are chronically infected with hepatitis C. So this is reiterating information that we've discussed, but reminding us that injection drug use is the primary risk factor for past and new Hep C infections in the United States. Again, the estimates on how many people are currently living with Hep C has a range, so anywhere from approximately 2.4 to 3.5 million in the United States. And the estimate, again, is about 65 to 70% are current or former persons who inject drugs. And then, as we've also mentioned, the incidence of hepatitis C has nearly tripled since 2010. And the age group 20 to 29-year-olds are the most at risk for acute hepatitis C. So when we think about hepatitis C, it's really a tale of two epidemics. So the one epidemic on the left is the increase in drug overdose deaths that has occurred throughout the 2000s. And if we look on the right, that map has a pretty consistent overlay with where we see acute hepatitis C incidence in the United States increase. Probably everyone is familiar with this graphic, but this is looking at opioid overdose deaths between 1999 and 2018. And you can see that opioids, particularly since 2013, synthetic fentanyl and its analogs are leading the cause for opioid overdose deaths. This is looking at national data and looking at past year opioid misuse, opioid use disorder, and initiates to opioid use. And you can see that on the left-hand side, all age groups have past year opioid misuse. And you can see that it's been pretty stable between 2018 and 2019. This is obviously pre-2020 data. And on the right-hand side, on the upper graph, you can see that pain reliever misuse is very common among individuals, and that's consistent from 2016 to 2019, though pain reliever use disorder and pain reliever misuse initiates are obviously far lower numbers. If we look on the bottom on the right-hand side, you can see that heroin use has decreased slightly between 2016 and 2019. Heroin use disorder has been also decreasing, and the number of initiates also decreased in 2019. So as I mentioned, the infectivity of hepatitis C is higher than HIV. So hepatitis C is at least 10 times more infectious than HIV. So the risk of acquiring hepatitis C is approximately 3 to 10% per injection compared to 0.3% for HIV. Contaminated needles and syringes are not the only vehicle for bloodborne hepatitis C transmission. As I mentioned, it also lives in the other works that are used to prepare drugs for injection. So the virus remains infective in liquid, syringes, and on inanimate objects for weeks. Hepatitis C infection is rapidly acquired after initiation of injecting, and incidence rates are highest among newer injectors, 25% who are infected within the first 2 years of injecting. So as I mentioned, hepatitis C is viable pretty much via all injection equipment. So when we talk about the term works, we're talking about needles and syringes, alcohol pads, a cooker, which is used to prepare drugs, sterile water, which is added to drugs to cook them, cotton, which is used as a filter, and people draw up their drugs through the cotton, and then other items such as ascorbic acid, which may be added to the drugs, a tourniquet to tie off an arm, a Band-Aid gauze, bleach if someone is reusing their needle and syringe, and a sharps container. So if we look at source and risk, and this isn't only for hepatitis C, but this is also regarding other infections such as bacterial infections. So if we look at the syringe source, the safest use of a syringe would be using a new and sterile syringe every single time. The riskier would be rinsing a syringe with water and liquid soap if no bleach is available. And obviously, there's every iteration in between on a continuum from safest to riskiest. If we look at a water source risk, the safest is to use sterile water from a sealed vial every single time. Riskier would be using water from puddles or other stagnant sources like toilet water, which obviously are rife with bacteria such as Pseudomonas. And obviously, again, there's every iteration in between on the continuum from safest to riskiest with respect to water. So how long does hepatitis C live on inanimate objects? I think many people are quite surprised by this graphic. As we can see on the filter or a cooker, which may be used to cook the drugs for injection, that would be about a day that hepatitis C can live. If we're talking about, I'm sorry, I misspoke. So for the filter is the cotton that is used to draw up drugs from the cooker. The filter can have hepatitis C that's viable on it for about a day. The foil or the cooker the drugs are prepared in has hepatitis C that's viable for about 3 days on it. A surface that is used to prepare drugs can actually have viable hepatitis C for up to 3 weeks, as can a water container. However, most surprising is that hepatitis C can actually live viably in a used syringe for up to 65 days. So hepatitis C contaminated solution needs to be heated for almost 90 seconds and reach high temperatures in order to inactivate the hepatitis C and make it non-viable for transmission. So why do safer injection practices matter? They matter because if people can learn to use their drugs more safely, they're less likely to transmit hepatitis C to someone else or to acquire hepatitis C. So persons who are injecting drugs should be taught how to use their injection equipment in a safe manner. And this can be done at a syringe service program or at a harm reduction program, et cetera. And this is to avoid outbreaks like we saw in Scott County, Indiana in 2015. So some persons who are injecting drugs to avoid hepatitis C or to not transmit hepatitis C to persons who don't have hepatitis C do something called serosorting. So this means that they only inject drugs with others that are the same serostatus of hepatitis C as they are. So if we look on this particular graphic, you can see that the persons who are having the riskiest use of their drugs are partners who are less than 30 years old with anybody who has hepatitis C within the group participating. And the safest persons are those who have partners that are only older than 30 years old. And then in between, you have partners greater than 30, but someone has hepatitis C within the group, all the way back up to partners less than 30 who have any hepatitis C in the group that they're using their drugs with. So persons, if they're aware of their hep C status, again, can take harm reduction measures to be sure that they are not putting themselves at risk of transmitting to someone else. And if they do not have hepatitis C, that they are not acquiring it from others. So how do we prevent hepatitis C in people who inject drugs? There are 3 points at which we can intervene: before exposure, at the point of transmission, and after exposure. So before exposure, we can be sure to test and counsel people about hepatitis C. If people have a substance use disorder, particularly opioid use disorder, we have very effective treatment to treat opioid use disorder. We can use harm reduction techniques and reduce transmission from positive partners to others. And we can vaccinate people with versus hepatitis A and B, and perhaps someday we'll have a vaccine for hepatitis C. At the point of transmission, we can educate people so that they change their injecting, sniffing, smoking, or skin popping behaviors. So there should be no sharing of any drug paraphernalia, regardless of the drug that's used and regardless of how the drug is used. And we can make sure that folks have access to clean drug paraphernalia through syringe exchange programs and harm reduction access points, as well as writing prescriptions for syringes for patients, which is a New York State Department of Health best practice. So after exposure, again, we can test people for hepatitis C with both the Hep C antibody and the hepatitis C viral load, and making sure that people who use drugs have access to hepatitis C treatment with direct-acting antivirals. So let's talk about the importance of testing, linking to care, and treating hepatitis C in people who use drugs. So if we look at the hepatitis C treatment cascade, and this is from a couple years ago, so it probably is not completely accurate with respect to the achieved SVR since we've had direct-acting antivirals. There's been higher uptake of hepatitis C treatment. But you can see that there's a huge drop-off at each part of the cascade. So between the estimate for how many people are infected to those who are diagnosed and aware, to having access to outpatient treatment for hepatitis C, to actually having a viral load confirmed for their hepatitis C. Liver biopsy is a moot point at this point in time. Very few people need to undergo a liver biopsy, but it was important historically. To people getting actually prescribed Hep C treatment, to people actually achieving cure or sustained viral response. So if we look at the hepatitis C treatment cascade among people who inject drugs, it's even worse than the general population. So far fewer people who inject drugs are actually identified as having hepatitis C, are aware and diagnosed, actually confirmed having hepatitis C with a viral load, and then actually have access to treatment. So we need to do interventions to enhance the hepatitis C care cascade. So that means making sure that people are educated, they're tested, and then most importantly, if they have a positive test, that test is confirmed to allow us to inform the patient whether they have active chronic hepatitis C or active acute hepatitis C, or a history of hepatitis C exposure and have cured. We'll go into a little bit more detail on that in a little bit. But it's also important that we talk about prevention if patients do not already have hepatitis C, or if they've had hepatitis C and cleared it, that we still discuss prevention with them so that they don't expose themselves again. They may not be as lucky and clear their hepatitis C next time. And most importantly, that we link people to care if we're not able to treat for hepatitis C ourselves. So I'm going to reiterate the hepatitis C testing recommendations, again, that were updated by the CDC this year. The CDC now recommends one-time hepatitis C testing of all adults 18 years and older and all pregnant women during each pregnancy. And the CDC continues to recommend people with risk factors, including people who inject drugs, be tested regularly. So what are the OASAS regulations regarding hepatitis C testing? OASAS regulations require that program policies and procedures address screening and testing for HIV and hepatitis C, and as soon as possible after admission, HIV and hepatitis C testing must be offered and may be conducted on-site or by referral. So what are the OASAS recommendations regarding hepatitis C screening and counseling? As I mentioned, all persons should be screened for hepatitis C antibodies and receive their test results in a timely manner with documentation that they received the results in their patient record. Patients who screen negative but have ongoing risks, for example, they have positive toxicology results for any drugs, should be screened at a minimum annually. Patients suspected to have active hepatitis C should be screened with a hepatitis C RNA test or viral load in addition to a hepatitis C antibody test, and they may be in the window period to manifest a positive hepatitis C antibody response, which can take 8 to 10 weeks after exposure. So again, they may only have a positive hepatitis C viral load and not yet have a positive hepatitis C antibody test, and that would define acute hepatitis C. All patients who screen positive for hepatitis C antibodies must have a Hep C RNA test or viral load in order to determine whether they have a chronic infection or not. So this test should be conducted by the lab at the same time as the antibody test in something called reflex testing. All patients who screen positive should be made aware that they will always screen positive for the antibody, even if treated and cured of hepatitis C. Brief post-test hepatitis C counseling should be made available to all patients. Those who screen positive for hepatitis C antibodies should be counseled about the need for further testing and evaluation with a hepatitis C viral load, and basic health information and the availability of effective hepatitis C treatment which cures hepatitis C. Those who screen negative should be counseled on risk reduction and prevention strategies. So this is a hepatitis C testing algorithm. So this is how we recommend that the testing be done to identify current hepatitis C infection. So starting at the top, if somebody tests negative with a hep C antibody and there is no suspicion that they could have acute hepatitis C and their test is non-reactive, then they do not have hepatitis C and they can just get education that's appropriate for whatever their risk factors are. If somebody tests positive with hepatitis C, in other words, their test is reactive, you are not done. You must check the hep C RNA or viral load. If the hep C viral load is not detected, then they do not have a current hepatitis C infection. However, they have had previous hepatitis C exposure. Ideally, that viral load test should be repeated in 6 months so that you have documentation at 2 points in time, 6 months apart, with a negative hepatitis C viral load to determine that that person has spontaneously cleared their hepatitis C, assuming they haven't been treated previously for their hepatitis C. If that hep C RNA or viral load is detected or positive, that indicates that someone has a current hepatitis C infection and they need linkage to care for hepatitis C treatment, which is curative. So how do we counsel patients depending on what their hepatitis C results are? So for patients who have a negative or non-reactive hepatitis C antibody test result, we discuss the meaning of the test result, discuss the possibility of hep C exposure during the past 3 months, and need to consider retesting. So if somebody has ongoing risk and they had a negative hepatitis C antibody, again, if you're concerned for acute hepatitis C, you check the hepatitis C viral load even if the antibody is negative. Or if the person has ongoing risk, then you would repeat the hep C antibody at a frequent interval. Again, that test may not show positive for up to 10 to 12 weeks. Discuss hepatitis A and B vaccination. If the person has not been vaccinated previously, then vaccinate them. And reinforce personal risk reduction strategies. So do not share any drug paraphernalia, including but not limited to needles, syringes, cookers, ties, water, stems, which may be used to smoke, crack for instance, or straws, which may be used to inhale drugs. Provide referrals to syringe service programs for all patients who continue to inject as their route of administration, or write prescriptions for needles and syringes, and encourage people to use condoms. For patients with a positive reactive antibody test result, how do you do counseling? Discuss the meaning of the test result, including that they were exposed at one time and are probably infected. So people who have been exposed to hepatitis C have an 80% chance of having a chronic infection and a 20% chance of spontaneous clearance. Discuss the need for follow-up testing with a hepatitis C RNA test, which hopefully was done reflexively to determine if they are currently infected, and a detectable hepatitis C RNA test or viral load would indicate current hepatitis C infection. So discuss hepatitis A and B vaccination and vaccinate them if they are not previously vaccinated or immune. Discuss the recommendation to avoid or limit alcohol intake. Again, liver fibrosis can progress more quickly if someone is also using alcohol. However, alcohol is not a contraindication to hepatitis C treatment. And remind people who have chronic hepatitis C not to share any personal hygiene items such as razors, toothbrushes, tweezers, or nail clippers. They should have dedicated hygiene supplies to themselves. So what kind of counseling do we do for patients with a positive Hep C antibody test and a negative Hep C RNA test or viral load? Discuss that this means that the patient was infected at one time and either cleared the virus on their own or was successfully treated previously. Discuss the fact that the hepatitis C antibody will be present for the person's lifetime in their blood work, and it does not mean that they have immunity. In other words, if they were exposed to hepatitis C again, they could become reinfected with hepatitis C. How do we do counseling for patients with a positive Hep C antibody test and a positive Hep C RNA or viral load result? Discuss the need for medical care and availability of curative Hep C treatment. Discuss the effects of alcohol and hepatitis C. With pregnant patients, discuss clinical practice guidelines. So currently, no hepatitis C treatment is approved for pregnant or breastfeeding persons due to a lack of data. However, those trials are currently ongoing, and hopefully we will have data soon. Breastfeeding is not contraindicated with hepatitis C unless the nipple or the area surrounding the nipple are cracked or bleeding. Discuss the risk of transmitting the virus to the child and the need to ensure that the child is tested at 18 months of age. Prior to 18 months of age, if the mother has hepatitis C, then the child could test positive merely from the mother's antibody. So the recommendation is to check at 18 months of age. The risk of vertical transmission, so from mother to fetus or mother to child during the birth, is approximately 6%. And encourage that all sexual and needle sharing partners of the person infected with Hep C get tested for hepatitis C. Provide counseling or refer to counseling for coping with emotional consequences of testing positive and behavior changes that will be needed to prevent the spread of hepatitis C. Provide or refer to needed medical support services. Provide information on the prevention of the spread of the person's infection to others. So do not share any drug paraphernalia, including but not limited to needles, syringes, cookers, ties, water stems, or straws, and provide referrals to syringe services programs for patients who continue to inject. Provide a referral for medication for opioid use disorder as appropriate for persons willing to take medication for active opioid use, regardless of their desire to stop using. Obviously, we know persons who are on medication for opioid use disorder with either buprenorphine or methadone have a lower risk of having a fatal or non-fatal overdose. So even if the person is not interested in stopping their use, the medication for opioid use disorder will help them decrease their risk and decrease their use frequency. Remind them not to share personal hygiene items such as razors, toothbrushes, tweezers, or nail clippers. Remind them to use condoms for sexual intercourse and cover cuts and sores on the skin. So what are the OASAS recommendations regarding linkage to care for hepatitis treatment? So all medical staff and counselors should receive updated hepatitis C trainings that reflect the current standard of care. It is recommended that staff should be trained on Hep C best practices a minimum of every 2 years. So staff should be providing on-site hepatitis care and treatment where possible. Programs that are unable to offer hepatitis C RNA or viral load or genotype testing, liver fibrosis staging, or treatment on site should establish a concrete referral system, including linkage agreements with medical providers experienced in treating hepatitis C. These referrals should be documented in the patient case record. Substance use counselors and medical providers should review the status of hepatitis C care for patients with chronic infection as part of their treatment recovery plan and help facilitate access to care when only available off-site. Just to inform everyone, there is a New York State hepatitis C patient navigation program, which provides many services, including outreach and enrollment, hepatitis C rapid testing, hepatitis C education and health promotion, treatment readiness and adherence counseling, linkage to hepatitis C medical care and treatment, and referrals and assistance in accessing supportive services, and provides supportive services itself. And the website is at the bottom of the screen. So what are the AASLD IDSA hepatitis C treatment recommendations? They're pretty simple. treatment is recommended for all patients with chronic hepatitis C infection. As we can see here, the recommendations from AASLD, it's for hepatitis C treatment in people who inject drugs, are strongly recommended. So people who inject drugs should be counseled about measures to reduce the risk of hep C transmission to others, and they should be offered linkage to harm reduction services when available, including syringe service programs and substance use disorder treatment programs. Active or recent drug use or a concern for reinfection is not a contraindication to hepatitis C treatment. So why is it important that we treat hepatitis C in people who inject drugs? So it's actually a public health imperative. We will reduce hep C transmission in the community by treating people who are actively injecting drugs. The more people that we treat who are currently injecting drugs, the more we will be able to tackle acute incidence of hepatitis C. So who are the priority populations and the settings identified by the New York State Hepatitis C Elimination Task Force? So for the populations, it includes people who use drugs, who are currently or formerly involved in the justice system, baby boomers, persons who are homeless or at risk of becoming homeless, and HIV positive individuals. The settings that have been identified as priority settings include correctional facilities, including jails, courthouses, and prisons, harm reduction programs, substance use treatment programs, primary and routine healthcare offices, such as community health providers and federally qualified health centers, and settings serving the homeless population. How is hepatitis C elimination achieved? It has to be a multi-pronged approach. So it involves planning to achieve hep C elimination, coordination between various sectors serving high-risk populations to achieve hep C elimination. It includes micro-elimination in particularly high-risk populations, such as people who inject drugs, to achieve hep C elimination. Better screening and linkage to care programming to achieve hep C elimination, awareness and education to achieve hep C elimination, expanding prescriber base to achieve hep C elimination, and a national hep C registry to achieve hep C elimination. What is the human cost of untreated hepatitis C? Unfortunately, there are many complications of untreated hepatitis C, including advanced liver fibrosis or cirrhosis, decompensated cirrhosis, hepatocellular carcinoma or liver cancer, and liver transplant. So let's move into more information about treatment. So hep C treatment adherence rates among people who use drugs are almost exactly the same as compared to the general population who is not actively using drugs. So the cohort that I'm discussing includes individuals who are active injective drug users, individuals with a history of injection drug use, active drug users not injecting, those that are HIV and hep C co-infected, and those who are on medication for opioid use disorder. So people who inject drugs or people who use drugs achieve high cure rates with direct-acting antiviral therapy, again, comparable to the general population. So let's go through a summary of the hepatitis C clinical trial data for people who use drugs. So regardless of the hep C treatment regimen studied and whether or not persons are on medications for opioid use disorder or not, cure rates were exactly the same. Regardless if baseline urine toxicology is positive for illicit drugs and urine toxicology is positive for illicit drugs during hepatitis C treatment, cure rates are the same. Regardless of usual care, group treatment care, or directly observed therapy for people who use drugs for hepatitis C treatment, cure rates were the same. Regardless of usual care plus incentives, usual care plus peers for people who use drugs, hepatitis C treatment uptake and cure rates were the same. Regardless of a history of injection drug use, recent injection drug use, or current injection drug use, cure rates were the same. Despite imperfect adherence among some people who use drugs, cure rates were the same, showing us that the drugs to treat hepatitis C are somewhat forgiving drugs with respect to adherence. What is the summary of hepatitis C real-world data for people who use drugs? Regardless of usual care, partial directly observed therapy, or complete directly observed therapy, cure rates were the same for people who use drugs on medication for opioid use disorder across multiple studies. Regardless of current injection drug use, recent injection drug use, or a history of injection drug use, current rates for people who inject drugs were the same. Observed in the real-world data, loss to follow-up often is due to an unintentional fatal overdose, again, reinforcing the importance of engagement and retention in care and of prescribing medication for opioid use disorder for people actively using opioids or drugs that may be mixed with opioids, such as psychostimulants. Hepatitis C treatment adherence in people who use drugs on medications for opioid use disorder was comparable to clinical trial treatment adherence rates. Regardless of the treatment regimen used, cure rates were the same for recent people who inject drugs, regardless of use of medications for opioid use disorder and illicit drug use. So there are low reinfection rates for people who use drugs. I think this is a huge concern for some providers who are reluctant to treat people who are actively using drugs or people who recently stopped using drugs. But if we look across the world, the reinfection rates are actually quite low. And really, if you never get a reinfection rate in your patient population, that shows that you are not really engaging an active population of people using drugs at this moment in time. So again, those reinfection rates are pretty consistent worldwide, a little lower in Western Europe than they are in the US, Canada, and Australia. But again, the average is 2 to 3% of your patient population will experience reinfection among your population actively using drugs. Despite the data that I just shared with you about the efficacious medications in the population of people who use drugs, there are still many stigmatizing restrictions on hepatitis C treatment in the United States. This is improving, but unfortunately there are still limitations. So for example, limitations on receiving treatment if you don't have advanced liver fibrosis or cirrhosis. So waiting till someone has extensive liver disease before treating them and preventing their liver disease. There are sobriety restrictions, which have no evidence to support them. And then there are provider restrictions. For example, primary care providers not being allowed to prescribe hepatitis C treatment, only specialists such as gastroenterologists, hepatologists, or infectious disease specialists. Treating hepatitis C is very simple from a medical perspective, so there's no reason for those prescriber restrictions. And why is this data important that I'm sharing with you? Because despite the data that I've shared with you, many physicians are still unwilling to treat people who are actively using drugs or recently stopped using drugs with hepatitis C treatment. So in this survey, 52% of physicians queried said that patients needed to have 6 months of abstinence before they would give them treatment for hepatitis C. Again, this is not evidence-based. 35% of physicians said that patients didn't need to be abstinent for 6 months, but they couldn't be actively using. Only 15% of physicians who took this survey would treat active people who inject drugs. And again, none of this is evidence-based. So why do I think this happens? I think this happens because of stigma. So stigma plays a huge role, unfortunately, towards people who use drugs in our healthcare system. So what does that stigma do to people who use drugs? It causes poor health services access and uptake, poor social and emotional well-being for the person who's being stigmatized, marginalization, and it actually increases their risky behaviors and risky situations because of their response to the stigma they experience. So unfortunately, there's a cycle with respect to stigma. So stigma leads to stereotypes and labels, to expectations and roles, and to limited opportunities, and then these are internalized and reinforced. So when we stigmatize persons who use drugs and exclude them from hepatitis C treatment, we are perpetuating the stigma they experience, and we are also reinforcing the hepatitis C pool in the community. So what are some harm reduction principles that we can apply with people who use drugs? So drug use exists on a continuum. Abstinence is one of many possible goals. Drug-related harms cannot be assumed, and people who use drugs are more than their drug use. They should never be defined by their drug use. So we should be targeting risk and harms to people who use substances, understanding that the roots of these risks and tailoring interventions to reduce them. We should acknowledge the significance of any positive change that people who use substances make in their lives, and accepting people who use drugs as they are and treating them with dignity and compassion should be the standard of care. We should protect the human rights of people who use drugs, and we should maintain transparency in decisions about interventions as well as their successes and failures. So let's look briefly at the hepatitis C treatment options. So all of these drugs are approved to treat hepatitis C, though the ones that are most commonly used, I will share as we get to them. So the first drug is a combination of elbasvir and gracepivir. So this is used to treat genotype 1 and genotype 4. What I do want to say is that all of these drugs are approximately equally efficacious in curing hepatitis C. Again, regardless of whether people are currently using drugs or not. So that regimen is one pill once a day, most typically for 12 weeks, though it can be extended to 16 weeks with ribavirin added in a certain subpopulation of patients. I'm not going to go into those details for this talk. The second drug is ladipasvir combined with sofosbuvir, and this is for genotypes 1, 4, 5, and 6. The treatment duration is one pill for 8 weeks for individuals that have a viral load of less than 6 million at baseline. However, that is not the case if the person is co-infected with HIV or if they're African American. So others would be extended to one pill once daily for 12 weeks. Again, this is also less commonly used. The next drug is sofosbuvir with valpatisvir. And this is a pan-genotypic drug, so this is most commonly found on insurance formularies because it can be used to treat any genotype 1 through 6. This is one pill once daily for 12 weeks. The next regimen is glecaprevir combined with pibrentasvir, and this is 3 pills once daily with food anywhere from 8 to 16 weeks. Again, I'm not going to go into the details of that. Most typically, it's used for 8 weeks. This is also pan-genotypic, so this is the other medication that is most commonly found on patients' insurance formularies. The last medication is sofosbuvir combined with valpatisvir and voxilaprevir. As you can see, this is a 3-drug combination rather than a 2-drug combination. This is used for previous treatment failures with direct-acting antivirals. So again, this would not be the most commonly used drug that I would expect people who are new to treatment to be using with their patients. And this is one pill once daily for 12 weeks. So very few patients experience any side effects on any of these regimens. The average is that less than 10% of patients will experience any side effects at all. However, the most common side effects that people experience are nausea or vomiting or diarrhea, headache, or insomnia. So to combat the low risk of having side effects, I suggest to people that they take their medication in the morning after eating. So again, it does not cause any GI upset, and it does not cause problems with sleeping. There are some drug-drug interactions to be aware of, and obviously if you're prescribing a regimen of Hep C treatment, you should cross-reference any of the patient's current medications to be sure there are no drug-drug interactions. Methadone and buprenorphine demonstrated no clinically important interactions with direct-acting antivirals, and these combinations are considered safe. Heroin does not appear to significantly interact with any of the currently available direct-acting antivirals. And then a specific class of medication, the NS3-4A protease inhibitors, which again, you can reflect back to the slides I just went over to see which drugs fall into that class, have the potential to increase serum concentrations of cocaine and methamphetamine, and this combination should be used with caution. So let's go over some conclusions in discussing hepatitis C in people who use drugs. All persons with hepatitis C should be treated and retreated as needed, regardless of active drug use. Outcomes or a sustained virologic response at 12 weeks status post completion of treatment are the same regardless of active drug use. So screen all patients for hepatitis C with reflex viral load testing for positive reactive hepatitis C antibody tests and link patients to care or treat them on site. Having innovative models of care, including via telemedicine, open access, low threshold, are more likely to engage people who use drugs and retain them in care, and test frequently persons with ongoing risk. Offer medications for opioid use disorder to patients willing to take them, as it will decrease their risk for both fatal and non-fatal overdose. Practice harm reduction principles in your practice. Truly meet people where they are at, not where you want them to be. Be compassionate and non-stigmatizing in your language and care. Everyone has a story to their life. You may not know their story because you have to earn their trust, and that comes with honesty and empathy and compassion. So if you have any questions or need assistance, please send requests to learningthurs@oasis.newyork.gov. And if you have any particular questions regarding this presentation, please feel free to email addictionmedicine@oasis.newyork.gov, and I will get back to you with appropriate answers. And thank you very much for your time.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.